This is Dr. Sargisian, and today we'll talk about alteration of digestive system. And this is an overview of digestive system, and which also includes liver and pancreas. One of the most common disorders an alteration of GI system is gastrointestinal bleeding. So bleeding can be upper and lower. And upper we consider esophagus, stomach, or duodenum. And lower GI bleed is below the ligament of Treitz, or bleeding of jejunum, ileum, colon, or rectum. So that ligament of Treitz is kind of the border, and also the color of the bleed may change. Like the brighter the blood is, the lower it is, and this is kind of one of those nursing things from day one you started working as a nurse, or the first month you definitely had someone with GI bleed presenting. And patient, if they have upper GI bleed, they may present with hematemesis, which is bright red blood, vomiting, coughing up blood. Sometimes can be confused as hematemesis, and coughing up blood is not hematemesis. When you're taking patient's history, please ask to clarify where the blood's coming from, because sometimes patients would see blood, they said, oh yeah, the blood came out of my mouth, but it was not hematemesis, it was hemoptysis. So perfuse bleeding during the vomiting, or blood mixed with vomit, or perfuse blood, it's hematemesis. Also, hematemesis is considered when patient is having coffee ground emesis, somewhat digested blood in the stomach, but patient vomiting that. Also not a good sign. Remember that this is medical emergency, no questions asked. This is one of the things you have to transport patient to ER as fast as you can, and the patient need to have upper endoscopy with cauterization or whatever needs to be done to stop it, because there may be several causes for this, not just ulcers, bleeding. Hematochezia is blood in the stool. So sometimes people would call hematochezia melena, which is not correct. It's a profuse red blood in a stool. Melena is dark, tarry stools, black stools. You don't really have no way to say that melena is blood in the stool, but definitely, or most of the time, melena is blood in the stool, the black tarry appearance. However, let's say with overuse of Pepto-Bismol, patient may present with black stools, tarry stools. So another history taking hint: if patient complains of melena, they say they have black tarry stool, make sure that they weren't taking Pepto-Bismol or any other bismuth preparations which can discolor the stools. Occult bleeding is occult. You don't see it by when you are observing the stools, when you are examining the stools. However, it can be showing up on occult blood testing, and occult bleeding is a concerning sign because this may be representing a bleeding malignancy and representing colon cancer. So that's our upper and lower GI bleeds. Occult bleeding can be slow upper GI bleed. It even can come from dental disorders, or for example, patient had a tooth extraction and then had occult bleeding testing, and it came positive. Probably it's a good idea with that history to wait couple of more days and redo the occult bleeding testing, hemoccult testing. But even tooth extraction and swallowing some blood may result in occult bleeding or occult hemoccult positive test, which doesn't mean that bleeding comes from colon cancer or an ulcer or something like that. So overall, upper GI and lower GI bleeds should be considered and are medical emergencies because there is a risk of perforation, the risk of losing blood, and profuse blood loss anemia. Occult bleeding, on the other hand, it's not medical emergency. However, it may represent a serious condition like cancer and should be addressed fairly quickly and evaluated. In both cases, in lower and upper, endoscopy, lower and upper, is indicated for further evaluation. With occult bleeding, patient needs to proceed with a thorough diagnostic workup that will include CBC and to check for anemias, and also by CBC I mean truly hemoglobin and hematocrit plus the REDS RDW, and check for hypochromic and microcytic anemias, cells, MCV, MCHC, those type of things. But CBC also will be with differential may be useful, because if there are some type of cancer, to look for unusual white cells. But at the same time, occult bleeding may warrant both upper and lower GI to further evaluate for the source of bleeding. Dysphasia is difficulty swallowing, and there are two types of this: mechanical obstruction and functional obstruction. When we're talking about mechanical obstruction, this is some type of narrowing of esophagus, some type of stricture or a ring, such as like Schatzky ring, a ring of connective tissue, scar tissue that occurred, and usually this is a consequence of gastroesophageal reflux disease. Another more concerning sequela or pathophysiology of dysphagia is having a malignancy or a benign tumor that causes obstruction and difficulty swallowing. So that's the dysphagia. So patient will have complaints such as food getting stuck right here and showing behind the sternum, may complain of chest pains related to food ingestion. Of course, we are very vigilant about chest pains, and you have to, every time is chest pain complaint, you have to distinguish, is this cardiac complaint, is this emergency, or is this something like GI related, definitely. So you have to examine the correlation of food ingestion and chest pain occurrence in this case. So food getting stuck, that will be the concern of patient, and sometimes patient would say, I have to rage, I have to vomit it, and they will say that they are having undigested food coming out. Achalasia is a very concerning disorder, and it's a denervation of the smooth muscle in the esophagus and lower esophageal sphincter. And what happened during the achalasia, the esophagus collapses and turns into very narrow passage or completely closes. So during the achalasia, patient would have build-up of food bolus and eventually would vomit it. Patient will have complaints of inability to swallow, and they will always rage. So again, dysphagia is difficulty swallowing. It's truly not related to pain. And the same in achalasia, they won't have the they won't have the complaints of pain, but they will be complaining of dysphagia, complaining of inability to pass the food, and they have to retch and get the food out without digesting. The complaint will be, I see the pieces of undigested food, and I see, it just doesn't go through. And achalasia is fairly emergent condition, not fairly, it's an urgent to emergent condition, because patient does not have ability to have food intake. Sometimes it's so tight, so even fluid intake will be difficult. And patient may experience, if this is untreated, patient may experience severe weight loss, nutritional deficiencies. So this needs to be treated, and one of the treatments is possibility of having Botox injection, and besides the cosmetic gastroesophageal reflux disease, it's also a disorder of motility. However, this is not dysphagia where food bolus cannot go down into stomach. It's opposite. The food bolus is going up, and it's a reflex of chyme from the stomach to the esophagus. Chyme is acidic substance, acidic mix. So esophagus isn't designed to have exposure to the acid. So this causes all type of problems such as esophagitis, or even strictures on rings, like I said, or even can predispose the patient for the esophageal malignancy. And gastroesophageal reflux disease will cause inflammation of the esophagus, and it will be called, of course, esophagitis. And the treatment may be directed to reduce acidity overall, as well as to try to recreate lower esophageal sphincter functioning. So that will be very hiatal hernia. Hiatal hernia is sliding of the part of the stomach into chest cavity, basically through the diaphragm, and in this case it may slide sometime, or it may be paraesophageal, just non-sliding hiatal hernia. But the problem is that lower esophageal sphincter doesn't have the help or diaphragm around it, so it's much looser and isn't able to hold climb down, and everything comes up. Unfortunately, lots of people have it. From empiric experiences, most people I saw having a EGD, they will have some degree of hiatal hernia. If it's paraesophageal hiatal hernia, it may be different manifestation than sliding hiatal hernia, but in both cases, gastroesophageal reflux disease symptoms can be present. It's, again, used to be very common to do Nissen fundoplication to try to deal with this and trying to reduce it, but it's a major surgical intervention, and the patient truly has to be very compliant with their lifestyle. And for instance, they cannot overeat, or they cannot vomit with Nissen fundoplication. That's why nowadays it's one of the last resort treatments, or surgical treatment for gastroesophageal reflux disease in general and hiatal hernia in particular. So you would try medication first before introducing anything else, like surgically. Peptic ulcer disease, it's breakage or a break or ulceration of the mucosal lining in esophagus, stomach, or duodenum, and it can have acute character or chronic. Patient may have superficial erosions versus deep through ulcers. Ulcers may perforate and bleed, causing peritonitis in severe cases. Also, they can bleed inside and causing acute GI bleed, which is also emergency. But in all cases, peptic ulcer disease most of the time is related to H. pylori. This is a picture of chronic peptic ulcer. You see the appearance and the white marking on the edges. So basically mucosa is completely destroyed, and you see like there is some blood discharge going on. It's approximately 2 centimeters in length, or even 2.5, almost an inch. And this may be very concerning. Even if it's chronic, it may exacerbate and perforate. So this may be a chronic NSAID user, like Goodies powder, most likely, or maybe something like, again, H. pylori infection, or altogether H. pylori with NSAID abuse, with cigarette smoking, with alcohol, altogether can cause this. But here you see typical white surrounding in the ulcers, showing that the mucosal layer is already damaged. So it's truly eventually what will happen. This may heal, although highly unlikely, but it may worsen and perforate, and perforation will become into peritonitis and needs again emergent treatment. Patient will. So the key is to address this early, to save patient trouble of dealing with peritonitis, to save them healthcare visit and all the consequences related to it. Duodenal ulcers are the most common ones, and they will be in the duodenum, and again, H. pylori will be one to blame. Basically, H. pylori is a very resilient bacteria that lives in acid and can produce toxins and enzymes that will be promoting inflammation and destruction and ulceration, and also hypersecretion of chloric acid, and pepsin will occur. NSAID used to blend gastrin levels if one of the things may be promoting the hypersecretion of acid. And also smoking we can blame on this too. And smoking also has indirect effect on this, because smokers will have lower or they will require more stimulation of taste. So they would like spicier food, they will use more salt, because unfortunately smoking, or fortunately, I don't know, smoking destroys the taste sensation. So you would need more spice, more, if you like hot foods, you will like more hot and spicy food, because your sensation is dull. So that also will promote acid production. So that's why smoking, besides of that, swallowing tar and all byproducts of smoke will be irritating to stomach. But again, number one here is certainly H. pylori infection, which has to be treated. Duodenal ulcer. You see here how this penetrates through layers, the ulcer crater, and mucosa destroyed, and submucosa. It even goes through muscular coat that goes that deep. And of course, this can also perforate. This is a picture of EGD. And esophageal gastroduodenoscopy, and also it shows the location actual ulcer in duodenum. So it's very interesting where it can be, and you see the blood vessels can be quite close to it. I mean, it's a relatively large vessel, and this can cause bleeding. The other problem here, if ulcers appear and then self-heal, lots of connective tissue appears, this can cause pyloric, not pyloric, but it will cause narrowing or stricturing in duodenum and inability to pass food. So patient may have bowel obstruction related to this, so with all the consequences. So another surgical intervention probably would be needed. So duodenal ulcers are common peptic ulcers. Again the same H. pylori to blame, NSAID use or NSAID overuse. Couple of words about NSAIDs. Goodies powder, most people who will present with peptic ulcers with Goodies powder, they don't think that Goodies powder is really medication. They think it's just, a powder, something like sugar you take when you have headache, and or people would take it for arthritic pain. But truly, there is no knowledge that it's a medicine. It's not some type of supplement. So that also, in my empiric experience, most of these type of ulcers were caused by Goodies powder. I don't know if there was research done, but empirically, what I've seen, definitely, I can say that yes, Goodies powder was to blame, or other NSAID preparations also may cause this. Gastric ulcers will develop in antral region because it's adjacent to acid-secreting mucosa of the body of the stomach. Antrum doesn't have that much acid secretion, so it's more, let's say, tender. So more, it can be affected much more by acid than the body of the stomach. Again, H. pylori to blame, and its mucosal permeability to hydrogen ions, and gastric secretion will be normal or less normal. Again, it may be even sometimes more than normal, secondary to overproduction of gastrin. But what happened, again, there is something else that causes gastric ulcers. It's not just acid goes from nowhere, decides to, I was saying it's not like acid goes from nowhere and decides to attack the stomach mucosa, antrum of the stomach, and but there should be something like H. pylori or NSAIDs or stress-induced ulcer. And here's another picture of the ulcer, and you can see some bleeding, very tiny small ulcer. It doesn't have a scale here, but you can see the bleeding in the stomach. It's and you really cannot even say, is this close to a perforation or not? Probably not, but it's significant blood. And this presumptively the photograph taken when patient was presenting with hematemesis, because considering the amount of blood on this picture, and the EGD has been done, and this is before they cauterize the ulcer. So let's talk about liver disorders. Liver disorders can be lots of different liver disorders, but once we truly concern, it's hepatitis and cirrhosis, and depending on the disorder, patient may develop portal hypertension. What portal hypertension does, the blood pressure in portal vein or portal venous system increases because of the resistance to portal blood flow. So this is like in kidneys, can be prehepatic, intrahepatic, and posthepatic. In this class and lecture, I'd like to focus on intrahepatic portal hypertension secondary to cirrhosis and hepatitis, and prehepatic and posthepatic also happen, but they are not truly that common. Portal hypertension by itself, let's say it doesn't have cardiac risk. However, it has very bad or negative consequences. What can happen because of increased hypertension, increased pressure in portal system, patient may develop varices, esophageal varices. Please imagine, not imagine, but that's the true fact, like the portal veins, they go they go to stomach, intestines, spleen, and they merge into portal vein. And the portal vein will branch, then go into the liver and get there. So if in liver it gets obstructed, then patient will start building up the pressure and developing pressure in all liver parts of portal systems. So the esophageal varices may occur, and also hemorrhoids may occur, and splenic congestion or splenomegaly may occur, and also ascites and hepatic encephalopathy because of the inability to get rid of waste products and of ammonia in particular. So let's talk about varices. Varices can occur again in stomach, and they can occur in rectum as hemorrhoids and lower esophagus. Most commonly, they will occur in esophagus, and by most commonly I mean the medical emergency wise, they will occur in esophagus. Varices are very vulnerable in esophagus, and they can open and break very easily if patient has somewhat unusual hard food bolus, or for some reason they overate, or without a reason really, because portal veins and they are not really designed to have that much pressure in them, so they will be rupturing. If esophageal bleed occurs, again, sometime it's very difficult to stop, and patient may unfortunately bleed out in addition to that vomit and aspirate. So this is a true medical emergency. This is when everyone moves very fast in the hospital, as you've probably seen, and most of the I never have seen, and thank goodness, patient being lost secondary to variceal rupture, because we always would take care of it very fast. But there are cases that it's not possible to address this because of the amount of the bleed and of the significance of the veins involved, of how much blood we're losing and how far the patient is from healthcare facility. Esophageal bleed or variceal bleed can be stopped by cauterization and banding of the varices, and the banding technique, same technique, can be applied to hemorrhoids in rectum. The problem with with esophageal bleed versus hemorrhoidal is hemorrhoidal bleed is easier to stop via conventional methods like prednisone suppositories or something else, or surgery, or just banding in the office, and usually hemorrhoidal bleed is not as severe as esophageal. But again, this is a true medical emergency and needs to be addressed very quickly. Any type of blood vomiting from patients any blood coming out from patient's mouth, it's an emergency, especially if it's a significant amount. Most likely bright red blood will signify esophageal bleed or esophageal variceal bleed, while coffee ground emesis most likely is bleeding ulcer, and melena is also can represent of anything, because melena is nothing but swallowed and digested blood. But esophageal bleed is again very emergent. And in addition to the treatment, in addition to endoscopical banding, patient may be prescribed beta blockers to reduce the pressure in portal system. Because of the increased pressure in venous system, the fluids will be sipping through the vein, and they will be collecting in abdominal cavity and causing ascites. Patient may need interventions as paracentesis to remove extra fluid, and sometimes patient will need lots of produce lots of fluid, 3 to 4 liters or more at one paracentesis session. To deal with ascites, the treatment may include diuretics, and diuretics we may have aldactone and Lasix mix, or combination of aldactone and Lasix to reduce ascites. So hepatic encephalopathy is another complication related, and this is secondary to buildup of ammonia and waste materials and causing cognitive changes. So when we're getting into hepatic encephalopathy, liver doesn't work well, and the toxins are building up. Ammonia getting more and more abundant in the blood, and it's getting into the brain, and also neurotoxins resulting from hepatic failure. Ammonia is not recycled, and it's not taken out, and it will affect the brain function, and a patient will start having personality changes, confusion, memory loss, unusual behaviors, and patient may become comatose and die because of that. Ammonia levels need to be reduced, and the most common treatment nowadays is still lactulose, although there are other treatments which by antibiotics which may cause the decrease of ammonia. But lactulose is very unpleasant treatment. Patient will have diarrhea, and non-compliance is quite common, and when patient starts being non-compliant, they will eventually slip into personality changes and confusions, and even end up in the hospital. So at that time, again, the lactulose or other treatments may be reintroduced. But there are more and more antibiotic oral treatments that may help with this versus lactulose. So let's talk about viral hepatitis here. Hepatitis A and B and C. And I would like to talk today only about A and B, and E and G, like you see here, very uncommon in US. D is requiring presence of the B for activation. So A, B, and C are the most common types, and those are viral diseases that will affect the liver. Hepatitis A, fecal oral transmission. and it can be excreted in feces, bile, and serum of the patient. And fecal oral route is most common, and again, it can be from crowded unsanitary conditions, also food and water contamination. Water contamination, sometimes having shellfish and shrimp or oysters from that lived in contaminated water, especially oysters, which may be consumed raw. And food, usually unfortunately it's a restaurant outbreak. There are studies done that the chances of completely recovering for a restaurant after hepatitis A outbreak 3 to 5 years, so that much like financial and reputation damage done. But for the patient, is the good news, it's usually most of the patients will combat this by themselves on having palliative care, really, and do not require medication and hospitalization. But it's definitely high morbidity disease, low mortality, high morbidity, and patients will be affected by this. They should be on somewhat isolation, like contact isolation at least, and their feces have to be isolated and decontaminated sometimes. So it brings lots of infectious control issues. Also, it brings also food service issues. This usually shouldn't happen, but it does, and it's usually come from one person who didn't wash hands after going to bathroom and serving food. So bottom line is, don't eat out as much as you like eating out. You are not the one who cooks that food, and there is no guarantee that you won't have hepatitis A, although it's understandable that every facility, every restaurant makes every effort to not introduce foodborne disease, but the chances of getting hepatitis A are higher if you eat outside versus you cook your own food. Besides, you will save lots of money on that too. So the bottom line is, this is disease with high morbidity, very low mortality. It's debilitating, and it will take lots of long time for patient to get back to normal, but usually patients will recover themselves. Approximately 10% people or so may have bad liver failure and may need further interventions from hepatitis A, but usually those people who have already some type of liver condition and hepatitis C or cirrhosis. That's why it's important, if you have a patient with hepatitis C or B, to immunize them for hepatitis A, because that will prevent development of hepatitis A on the top of hepatitis B or C. Hepatitis B is transmitted through contact with blood and body fluid. So it's not fecal oral route anymore, it's a body fluid transmission. Maternal transmission can happen, and vaccine is available, and if you work in healthcare, it's certainly a good idea to have vaccination. Treatment is also available for antiviral treatment for hepatitis B. However, again, the treatment process is very lengthy, and the results may not be, there is no 100% cure or 100% effective treatment for hepatitis B. The contamination or transmission occurs again through blood, body fluid, sexual contact, and contaminated needles. However, the rates of hepatitis B nationwide are much lower versus rates of hepatitis C. So hepatitis C is another blood-borne disease. There are many sources speculated about hepatitis C transmission. Sexual contact is blame, also like body fluids, but there is more and more evidence that Hep C is truly blood-borne disease. It's not going through body fluids much. And IV drug use is certainly implicated, and transfusion, blood transfusion, used to be one of the causes of hepatitis C transmission, but nowadays we screen blood very thoroughly, and this is virtually impossible to get hepatitis C or HIV from blood transfusion nowadays. But approximately 50 to 80% of hepatitis C will result in chronic hepatitis, and it all depends. 50 to 80% depends on genotype. So this is, but small percentage, approximately 20% on average, or less even, may develop immunity to hepatitis C and cure hepatitis C by themselves, patients. But they will be certainly, what I'm trying to say, people who develop immunity by themselves to hepatitis C are a focus of some studies trying to find vaccine for C, which is not available, or further learn more about hepatitis C and try to find more efficient medication. There are antiviral preparations for hepatitis C available, and the treatment is available, and there is approximately, depending on the genotype of C, cure rate can go up to 80% and like 50 to 80%. Again, I will not be asking you on exam or elsewhere that percentages of cure rates or the epidemiology and statistics, so this is just FYI information. But treatment is available, and hepatitis C stays long very dormant, and nowadays usually it's accidental discovery on routine blood test when patient present with elevated liver enzymes. Further workup will show that patient has hepatitis C, and sometimes the source of the disease is absolutely unknown, or we don't know where patient received it, but they may have contamination with needle 20 years ago, or they did some drug 30 years ago, they don't remember, but sometimes patients just have no clue where this appeared. And again, treatment is available, so every time you see your patient has hepatitis C, you may elect, you need to refer them for hepatology clinic or gastroenterology clinic for further evaluation and treatment. Again, brief hepatitis, the rest of hepatitis infections. D is fairly rare. It needs the hepatitis B for replication. So if patient doesn't have B, there is no way to develop hepatitis D. E is another type of hepatitis. It's virtually unknown in United States, although with the influx of immigration this may be increasing, but it's another hepatitis with fecal oral transmission. And the G is one of the newest hepatitis, and it's parenteral and sexually transmitted route. Major piece of information I want you to remember from this slide, it's about hepatitis D, that D needs hepatitis B for replication. That's a common question I would ask probably, or elsewhere you'll be asked. But a patient cannot have hepatitis B without hepatitis B. So D needs B. In general, when hepatitis infection occurs, this following sequence take place. They will have incubation phase, which is different from different types, prodromal, pre-icteric phase when patient turns jaundice, before patient turns jaundice, and icteric phase when patient develops jaundice, and recovery phase. If patient is having chronic hepatitis B or C, they may not even get into icteric phase. Because icteric phase is very remarkable in hepatitis A, and usually there are some lucky people who had infections with B and C, and they were able to recover themselves without any drugs. If they don't recover B and C, they will slip into phase of chronic hepatitis and gradual deterioration of the liver. Fulminant hepatitis appears from one or the other cause when the hepatocytes getting impaired and necrotic, and also acute liver failure can result from Tylenol overdose, getting more and more serious nowadays, the Tylenol overdose. The recent one I learned was buying sleep aids, Benadryl-based, like NyQuil, or not NyQuil, I'm sorry, Benadryl PM, or Tylenol PM, and taking it because the sedative qualities of it, and overdosing on Tylenol as an additional drug, although drug seeker is looking for Benadryl sedative qualities. But again, can be suicidal attempt to have acetamin overdose, and this is a true liver emergency. And I know the whole lecture today was about emergencies and true emergencies, but this is one of the worst situation you can deal if a patient presents with acute hepatic failure and acetaminophen overdose. This most of the time requires liver transplant, and because liver will have very small chances to recover. However, some patients may recover and overcome the acetamin overdose. But again, it's a true emergency. If you are facing something like this with your patients, this is need to be addressed with the closest transplant clinic, and patient needs to be maybe given transplant liver if they are candidate and if they meet all the criteria. This is different whole ball game. I don't want to go in there, but what you need to take from here, acetamin overdose will result in acute hepatic failure, which may require liver transplant. Cirrhosis is the disruption of liver function and structure. The function of liver is lost, and liver tissue will turn into nodular and then fibrotic and fibrosis. There will be less and less biliary channels, and liver becoming more and more obstructed and will cause portal hypertension. Because of that, blood doesn't go to the places in liver where it usually goes, so it also fibrosis adds to developing the necrosis. So cirrhosis is a sequela of either hepatitis or alcohol-induced hepatitis, but cirrhosis is not reversible. Even patient, let's say, stop drinking, but we still will have cirrhosis. So liver function is lost. Cirrhosis brings lots of other different issues of portal hypertension, like we talked, and also different other problems such as biliary obstruction, jaundice, ascites, and hepatic encephalopathy, but overall patient will have liver failure and death secondary to that. A patient with cirrhosis may be candidates for the transplant, and unfortunately patient needs to be abstaining from alcohol or any other illicit substances for 6 months to be considered a candidate, and most of the time, or not most of the time, but sometimes patient just will continue using alcohol and illicit substances and will not be qualified as transplant recipient. So cirrhosis can be alcoholic because alcohol puts lots of taxing on the liver. Alcohol damages hepatocytes. Every time you drink alcohol, you cause some damage to your liver. So avoiding alcohol completely is maybe the best thing you can do for your liver, but drinking shouldn't be excessive by no means. Binge drinking especially can cause severe damage. Of course, this may result in damage of hepatocyte. After ingestion alcohol, everybody will have somewhat elevated liver enzymes, although cirrhotic liver does not have elevated liver enzyme because most of the hepatocytes are damaged, so there is nothing much to damage. So biliary cirrhosis, this is a different disease where cirrhosis will start in bile ducts, and it's actually called primary biliary cirrhosis. It's autoimmune disorder, and there are ways to treat it with medication that will work on the immunity itself, versus secondary biliary cirrhosis, secondary to obstruction. In this point, alcoholic disease is definitely much more common than biliary disease. Post-necrotic is the consequence of chronic disease, again losing blood supply to the liver and getting less and less blood supply and necrotizing the liver. The last slide I'd like to talk is disorder of pancreas and disorder of pancreas as pancreatitis. So two major causes of pancreatitis. There can be, first of all, can be autoimmune pancreatitis, but it's not common. But two major causes, alcohol and gallstone or cholelithasis. What happened in both cases, both of the substances will cause injury to pancreatic cells and duct, and leakage will occur of the enzyme into pancreatic tissue and having self-digestion of the pancreas, and then leaking into blood vessels and causing damage locally into other organs. But this, at this point, I want you to know these two sources. Alcohol as a toxic substance to pancreatic cells and duct. And if alcohol has an influx somehow into pancreatic ducts, it will cause destruction right there. When we're having cholelithasis, small stones, small gallstones can go upward through the pancreatic duct and actually cause blockage and cause severe pancreatitis. In that case, ERCP may be recommended to remove the duct obstruction and just to release the inflammation of the pancreas. And after that, patient will have marked improvement within hours if the release is done, and if the obstruction and pancreatitis is secondary to biliary stone. Alcohol-related, the treatment will include MPO status, so not to encourage pancreas to produce any digestive enzymes, and also hydration, and most of the time. Also, patient has to be consulted heavily about alcoholism and consequence of pancreatitis. Although sometime you would see when patient come with alcohol-related pancreatitis. I had several people who had quit drinking after third or fourth recurring pancreatitis attack, and they finally made that correlation between alcohol and pancreas. And I can only imagine how hard it was to do that, but dealing with pain and hospitalization every time is also very difficult. And talking about pain, patient also will require pain management while they are hospitalized. There are other sources, obstructive sources, like dysfunction of sphincter of Oddi, but at this point for this course I want to limit our conversation to this, and this will conclude our lecture. Thank you very much, and call me and email me if you have any questions. Have a great day.